Hey everybody, this is Dr. Donish. In just a couple of minutes, we're gonna start, but since this is our first inaugural episode, I thought I would just get online and make sure that everything is casting correctly. And from what I can tell, it looks like it is. But if anybody is out there and listening, then please let me know if anything's not coming through, whether it's my voice or the video. Um, but from my standpoint, it looks like things are functioning well. So, Ella, would you mind grabbing me one of my books?
Absolutely.
And we'll get started in just a second. So it looks like we've got a single viewer. Thank you. Hi. Thanks for coming on, watching this show. As I mentioned, this is the inaugural show of 50 Shades of Pain. It's in response to my book, and it looks like we're in a mirror image. So if you can imagine this in the opposite direction, it's 50 Shades of Pain. The book is called 50 Shades of Pain: How to Cheat on Your Surgeon with a Drug-Free Affair. And the purpose of this show is to start educating the community about pain issues, about aging, how the body changes with time, and the things that, as we age, cause us to hurt, how we can get ahead of it, and how we can optimize our health. Because the reality is, pain is a universal experience. Everybody is going to, at some point in their lives, have a painful issue. How we address that is my concern, because the way healthcare has been approaching the issue has actually, in my opinion, created more problems than solutions. We see increasing number of people dependent upon opioids. We see more and more surgeries taking place, and yet a lot of the things that could preempt both of those issues are not being utilized in healthcare. The way healthcare is reimbursed is very skewed, and so it favors things that are more invasive, more disease-focused, more backwards thinking, in my opinion, than it does the things that are more proactive, health-oriented, and things that are really within anybody's domain of control. The problem I see with healthcare, the biggest problem is that it's disease-focused. We essentially wait until the engine breaks down to think about changing the oil, and it doesn't make any sense. Pain is essentially your check engine light, and if we do nothing more than just put a sticker over that check engine light and then continue to drive the engine and anticipate that it's going to be indefinite, it's going to last indefinitely, well, clearly that's not going to be the case. And that's the perspective that I want to bring with this show, is that if you're experiencing pain, there's a reason to it. There's a reason for it. And while opioids are an effective tool in certain situations, to depend on it lifelong or in a chronic setting as the mainstay of your care is problematic. Because whenever you're talking about a pain issue, there are three components to it. There's a tissue that has been injured and is creating a pain signal. There's the nerves that are transmitting that pain signal. And then there's the brain that hears the message from those nerves and interprets this as a problem that it needs to address. So if you're dealing with pain, you can rest assured that all three of these components are being affected, and there are changes taking place in all three. And where opioids work are primarily at the brain level, where those messages are already coming in. So it's the equivalent of watching TV with the volume turned down. I use this analogy a lot with patients. The first thing that people do when they can't hear the TV is what? Well, we all look for the remote, but then after we find the remote, we turn the volume up, right? So the same thing happens when you're dealing with opioids. It's the brain is seeing a message coming in, so it's seeing the TV is on, but opioids essentially turn the volume down. So the brain compensates by turning the volume back up. And then the next time you hit a commercial break, it's now too loud. The same thing happens with opioids. You are experiencing tissue that is damaged and sending nerve signals to the brain that the brain isn't hearing well. And so it turns the volume up. And when the, oh, it looks like, okay, all right, so we're still going. Okay, so when the brain sees that signal coming in, but it's not really hearing the message, what happens is that the brain turns the volume up, and when the opioids disappear, now you're dealing with a higher sensitivity of pain. So somebody who is, if you take two people with the same exact condition, one person is on pain medication and the other person is not taking pain medication, the difference between these two is the one who isn't taking pain medication still has fluctuations in their pain, whereas the one who is taking pain medication, when the medicine is there, their pain drops, but when the medicine wears off, they don't go back to the starting point. They actually become more sensitive to pain. So I'm not sure which camera is working, so I'm going to just focus on both of you guys. So what happens is that the person with opioids is fluctuating like this, whereas the person without opioids is fluctuating like this. And I'm not saying that opioids are a bad thing. They're useful. But the problem is that the science behind its utilization is primarily, has been primarily looked at intermittent use and for short durations. We've never had any studies that go beyond 16 weeks that demonstrate efficacy. There's never actually been any studies. And most studies that we look at, when you use an opioid for a prolonged period of time, you start to lose the benefit of it, and it actually starts to implement harms, being that your sensitivity actually goes up. That's the problem that I see with a lot of patients that come in, is they're actually experiencing what I term as supraphysiologic, or pain that is in excess of what their natural body responses to pain should be, and it's largely due to the chronic utilization of opioids. We are a nation that uses the most amount of opioids in the entire world. So if you look at the entire global U.S. population, we're only 5% of the global population, but by many statistics, we're using the vast majority of opioids. Some estimate 80% of all opioids are used in the United States. Now, you would assume that if that strategy has been effective in managing pain, then all of those people are going to be doing better than the rest of the world. But when you look at the statistics indicating who is in pain and how much pain are they rating, the U.S. actually ranks as number one in highest levels of pain across the entire globe. And in every demographic that you look at, numbers of people complaining about pain, and more of those people are complaining about higher intensity pain. So it doesn't make sense. The numbers don't make sense. If opioids are so effective, then why are we struggling so much with getting our patients in better condition, in better pain control? That's what we're here to focus on, is what do we need to do within healthcare to change this direction? And that's really the trajectory of this practice. We're not just treating our individual patients, a living laboratory in which collaboratively with our patients, we build the best model out there that helps people who do struggle with painful issues, but to help them live an optimal life so that physiologically they are as good as they physically can be. And that's, we have a lot of room for improvement in whether it comes from good nutrition, the appropriate type of exercise, not just any exercise, and an attention to how much the body is capable of healing itself if we give it that opportunity, if we facilitate it as opposed to getting in its way. And what I mean by that is that within healthcare, when we address a pain issue, we're not just addressing pain, we're also addressing tissue damage. And these two are not always one-to-one correlations. Sometimes you can do something that will help reduce the pain, but it will do nothing for the damage, and vice versa. Sometimes you can do something to improve the damage, but you're actually making the pain worse, if not no difference at all. Helping people understand that difference is what we can do. And these are the conversations that I want to have with you so that we can dispel some of the myths. There have been a lot of myths and misinformation that was primarily based out of pharmaceutical marketing than it was based out of science. And now that the evidence behind opioids is abundantly clear, it's not the right direction, we're able to better get into the details of what the marketing was based off of. And it's just evident that the science behind what was promoted was inaccurate, if not gross misrepresentations. And at some point down the road, I'll have a show where we focus just strictly on that, the misinformation and the myths that evolved a lot of the practice norms that we see within healthcare that are actually contributing to the problem as opposed to the solution. So how do we address this? How do we go back and we start fixing this problem? Well, what I talk about in my book, 50 Shades of Pain, is a methodology or a framework that I call HEAL. So HEAL is an acronym. It stands for, each letter stands for something. H stands for hearing the message that your body's trying to convey with pain. E is for envisioning what life is meant to be like. A is for alleviating symptoms, which is different than eliminating pain. And then 4 is leveraging what your body normally does to heal and facilitating that healing process. So I'm going to break it down in a little bit more detail. Starting with H, hearing the message that your body tries to convey with pain. A lot of times what happens is when you go to a doctor and talk about your pain issue, for so long the attention has been placed on symptom management that the immediate go-to is, let's get you out of pain. And that's great, that's important, but unless you're actually addressing the underlying cause of that pain and trying to understand what's causing that pain, you're only delaying the inevitability of trying to address this pain issue. So a lot of patients that we see have had years of mistreatment or bad or mismanagement where it's been strictly focused on symptom control or controlling that pain, not controlling the disease. And they have evolved two problems. One is that their pain has been mistreated or undertreated for years. And then the second is that the opioids are actually causing neurological changes that I discussed, that highs and lows, and it changes people's perception of how the brain receives those pain signals and how much it amplifies it. So H is for hearing the message that your body's trying to convey with pain. In other words, you see the check engine light come on, and instead of putting a black sticker over that check engine light, we actually start to diagnose the engine and figure out what's the pinpoint cause. It's not as easy as saying, you know, I've got knee arthritis. Well, the reality is that arthritis is usually starting off with a looseness within the joint, where you're starting to erode or damage the joint because it's moving in directions it's not supposed to. So as the body ages, you have fewer and fewer repair cells, but more importantly, you have weaker and weaker structures, and so things compound and they get out of control. So what we want to do is develop essentially what I call the pain map. The pain map is the things that are actually originating the pain, trace it down to the individual ligament, the individual tendon, the specific nerves that might be injured or entrapped, and figure out how we can identify this in a more definitive manner than just what an MRI or an X-ray shows. A lot of that is based off of ultrasound technology, because with ultrasound, we're able to see structures that would otherwise be missed. And more importantly, it's in real time. So I can take a look at a joint, stress that joint, and look at how the structures that are meant to keep the integrity start to lose their integrity. And then go beyond that by actually numbing the structure that I'm suspicious of, so that we can determine if numbing that one tiny piece of your joint will address the entirety of the pain, or if it will only address a part of the pain. But either way, we can progressively build a pain map using these diagnostic injections. So the second thing is E, for envisioning what life is meant to be like. One of the things that I see happens within healthcare is we go through this cycle of hope and despair, where you see a clinician, they give you their perspective or their opinion on what's going on, and then they go on to the treatment plan without really confirming if that's the problem. Well, a lot of times what that does is it erodes people's sense of the futility, or it gives them a sense of futility that there is a solution to this. Namely, if you are expecting benefit from a treatment that doesn't give you that benefit, how many iterations, how many repetitions of that can you go through before you start to think, well, there is no solution, or, well, there is nothing that my body's going to ever do to repair, or more importantly, feel disenfranchised from your own body, meaning that you feel like you don't have the control to heal or repair the damage. You're depending on external sources like a clinician to actually do that for you. Whereas that's not always the case. In fact, oftentimes the body is capable of healing so long as we give it the right instruction on how to heal. So the purpose of envisioning is to reconnect people with what their goals are, what are their aspirations, and what do they want to pursue, whether we can fix this problem that's causing pain, or whether we're helping people cope and adapt to that problem. It's not something that everybody enjoys hearing, but what they do enjoy hearing is the fact that there is hope. And I always tell patients, if there's three things that we need in healthcare, it's hope, hope, and hope. Because we don't do enough for inspiring people that there is life beyond a chronic illness, and how we can maximize or optimize them to live the most functional life that they can. A is for alleviating pain. And that's, like I said, different than eliminating pain. It's establishing realistic expectations that we're never going to eliminate pain, that the goal is to fix the damage, and hopefully that will reduce, if not eliminate, the pain. But it's impossible to eliminate pain if there's damage there. The best that we're going to be able to do is reduce the intensity of the pain and help people live more comfortable lives, as opposed to pain-free lives. When you set that bar so high, it's setting people up for that cycle of hope and despair. And in my opinion, that's one of the most toxic things that we can do for our patients, is give them false expectations that we'll never be able to reach, and then victim blame and say that because you're continuing to hurt, or because we haven't met that unrealistic expectation, the problem is within you. The problem is that you have a condition that's never going to be fixed, that you have a problem that you're not putting enough effort into, or that there really is no hope. And it's within that hopelessness that people opt for drastic maneuvers like surgery, which in many cases is overutilized, or it's an over relied upon resource, when very simple or much less invasive treatments can be effective. As we move through these talks, we'll talk more about the options that are out there as far as minimally invasive techniques that can replace, if not improve upon, surgical outcomes by reducing the damage that surgery and scarring does. We often forget that while surgery fixes some problems, it creates other problems as well, because you can't get into the body without creating scar. And so the less scar that we produce, the better off we'll be. And there are innumerable treatments that are already available, if not coming in the near future, that will make surgery, even arthroscopic, when they put a scope in, even that may seem more brutal in comparison to some of the needle-based treatments that we have. I'm getting a message on the computer. All right, so all right, that's a good message. Thank you, Ella. So the final element of the HEAL framework is leveraging what your body does to heal, and that has to do with understanding what happens when the body is injured and what do we need to do as clinicians to help facilitate the body actually healing versus trying to replace the whole system. Whenever there's an injury, there is tissue disruption, and that tissue disruption causes some degree of bleeding. Within that blood are cells that have growth factors, and as those growth factors slowly release over time, what happens is that they recruit other cells into the area, namely stem cells, or what we call mesenchymal stem cells, or MSCs. These are cells that live out in the periphery, in our arms, in our legs, but in highest concentration in our fat. And every layer of skin has a thin layer of fat in it. There are tons and tons of stem cells in those tissues, and those cells will respond to those growth factors being released and migrate to the area to start the tissue repair. What hinders that process is a lot of the things that help with pain, but really slow down the healing, namely anti-inflammatories, steroids, ice. Even the clinician, Dr. Merkin, who came up with the acronym RICE, or Rest, Ice, Compression, Elevation, has come out and said, look, we made a mistake. Ice is not a helpful technique in healing injury. It can help with the acute pain, and there's a balance between how do we address the pain versus how do we facilitate healing. But the point is that there is a lot that we do within healthcare that actually hinders the progress from that inflammatory stage onto a more healing or regenerative stage. Those are the things that we want to bring more attention to so that people understand the balance between how do we deal with the new injury, how do we cope with it, how do we tolerate it, and how do we help it heal faster. So a lot of the things that we're doing is using the pain map that we developed initially to then help guide our physical therapy, help guide our nutritional counseling, help guide any intervention that we're doing, whether it's to help reduce the impact of the pain to facilitate the recovery, or using some of the newer techniques like regenerative medicine injections, where we're using growth factors, medications, or even stem cells themselves to amplify and augment the healing process. Your body loses stem cells as we age. That's a reality. And the number of problems that we're trying to address with that fewer population of stem cells is continuing to grow. So what we try to do is get the critical mass necessary to heal an injury, and either facilitate the migration of stem cells into that area with a higher concentration of growth factors than what your body can produce, or mechanically take those cells and place them exactly in the damaged tissue in a higher concentration than what your body can produce, so that that area has the greatest opportunity to optimize and get to its most healing state. And that has a lot more involvement to it, and we can go into more detail in future episodes about how that happens. But that's the basic overview of our practice, of our philosophy at Wellward. There's a lot of other nuances to it, but that's the very basic framework, is the HEAL methodology. And if anybody is interested, this book, 50 Shades of Pain, it's a bestseller on Amazon, but you're welcome, and you're welcome to purchase it there. But if you're interested in getting the chapter that is entitled the 5 questions that every patient with pain should ask their clinician, we are happy to send that to you for free. You just have to get in touch with our practice and sign up for our email list, and we'll be happy to send that out to you. But we've priced the book as inexpensively as we can. You can get a Kindle version for 99 cents, and hopefully we'll be able to figure out our technology so that we can actually flash the URL at the bottom of the page. But if you just search for Amazon, there aren't that many people with my name, Danish Mazlamdoust. And while there are a few other books titled 50 Shades of Pain, you can very quickly see the difference between my book and their book, which is maybe a short-sighted titling on my part. But so I wanted this to be an interactive show, and I know that I've stimulated some questions out there. For the last 5 minutes, I wanted to see if there are any questions that that I can address. Let's see. So, are there any questions? Oh, we have a comment.
Yeah, you had a patient that commented that she had seen you previously and she's been doing great since.
Yeah, so
fantastic feedback.
Thank you for that. We have a lot of patients who've given us very positive feedback, and this is a community effort. I mean, we're a startup clinic. We are a small practice, but we have a very, very large, ambitious goal. Our eyes are much, much bigger than our tummies are, and any feedback, any kind of word of mouth about how we've benefited people, or any feedback for us of how we can do a better job, is very valuable to us. So don't be shy. If there are any patients who are any former patients or any active patients who are listening, or who listen to this once it goes off of live feed, by all means, please share the information, share the knowledge. I know that a lot of the things that I say, it's heavily rooted in science, but it's not common knowledge, even among clinicians. Even when I go and give lectures to physicians, the feedback I get is they had no idea. I'll give you just one example of a myth. One of the myths that I hear often said is, stay ahead of the pain with your pain medication so that you can always, so that it's not hard to catch up. Well, what is this based off of? It was based off of studies that looked at how do we prevent the neurological changes within the spinal cord and in the brain. Remember those three pieces, the tissue, the nerves, and the brain. How do we prevent the nerves and the brain from going into this red alert state? Because once you're in that red alert state, even something as simple as just touch feels painful. And you've all experienced that. If you burn your finger, it's not just the area that you burned, it's also that umbrella around the area that's sensitive. And that's because of that wind-up effect, the effect that the spinal cord and the brain have when they see pain on a regular basis. So that science was based off of how do we prevent the tissue from sending the signal to the spinal cord or the brain for those changes to take place. Opioids don't do that. They only affect at the level of the spinal cord or the brain, and more so at the level of the brain. So by that point, that wind-up effect has already taken place. The catch-up type of pain has already been there for a while. It's only effective when you block the nerve coming out of the tissue from sending the pain signal to the spinal cord or the brain. That's where that preemptive analgesia is what it's called, where that staying ahead of the pain is effective. It's not effective with opioids. So it was just a manipulation of the science to convey something inaccurate that in effect sells more pain medications. And we'll discuss more of those kinds of myths as we move forward in this series. But it's really important to have those conversations, to have a better understanding, at least, of what is accurate information, versus what is just a manipulation of the science for a special interest purpose. So
we have some events coming up.
Yep, that's right. I'm glad. Thank you, Ella, for reminding me. So our next episode is going to be about ketamine. Ketamine has been in the headlines for a lot of reasons. It's an old anesthetic, but we're finding utility in neuropathic pain, in people who've been exposed to opioids and have that opioid sensitivity, that volatility, as well as what's really fascinating to me nowadays is in depression. This has been, I thank the patients who have been willing to come out and talk about this, because it is a fascinating area. Within ourselves, we all have thoughts that we don't express. It's kind of like your day-to-day monologue in your head of how you perceive the world. And a lot of times that monologue can be very toxic to our health that we're not even conscious of. It's waking up in the morning and being, oh, I got to get up and go to work. It's that kind of a statement stated over and over throughout the day that starts to create a toxic effect. And the part of your brain that deals with depression also deals with pain. So the same chemicals that affect pain also affect depression. And that's where ketamine falls into play. What's even more fascinating about it is that it has a chemical reset effect, but it also has a kind of outside of yourself perspective. So you're able to view yourself, that monologue in your head, in a perspective that you may never have experienced before, or never thought about, or paid attention to. So we're seeing a dual purpose in depression that we'll get into next week, or next session, that's in a couple of weeks, of how ketamine has that effect, and what are some of the things that have come out in our experience using ketamine for depression. I encourage you to tune in if you're interested. I encourage you to tell friends and family. Like I said, we're a small practice who's really got an ambition to change healthcare, to transform healthcare, and as we say, take healing beyond medicine. So we appreciate anybody who's out there and helps us convey this to other people, and gets the message out about what we're doing in these bi-weekly shows. We're going to try to keep consistent with it, and introduce the other members of my team. The whole Wellward team is very excited about this whole project, and look forward to speaking with you personally on these venues. So feel free to give us more feedback and information. Thank you for paying attention and tuning in. I hope to see you soon. Thank you.